All right, let's dive straight into a high-yield review of some classic cardiorespiratory and vascular cases. We're kicking things off with 4 classic cases, all centered on vascular and obstructive pathologies. Okay, case number 1. So you've got an elderly patient, and their BP is 170/80. Now, what should jump out at you right away? That systolic number is way up there, but the diastolic? Pretty normal. This right here is what we call isolated systolic hypertension. And trust me, in this age group, it is not something you ignore. Let's dig into exactly why this pattern is such a big deal. So what's really going on here? The root cause is age-related arterial stiffening. I mean, think about it. As we get older, our arteries just lose that youthful stretch and elasticity. They become more like rigid pipes. And that lack of give is exactly what forces the systolic pressure to shoot up, creating that huge pulse pressure we saw, that 170/80. This is more than just a number on a chart. That relentless high pressure is hammering the delicate blood vessels in the brain. In fact, it's the single strongest predictor of stroke risk for older folks. So what's the big takeaway for your exams? It's simple. You have to treat this. The evidence is just rock solid. Bringing that systolic number down dramatically reduces stroke risk. And it doesn't matter if they have some mild kidney issues or even if they've had a stroke before. The go-to classic treatment that's been proven time and again starts with a thiazide-based diuretic. And here's the pearl to lock away. For older adults, it's all about that systolic number. That's the one that tells you the real story about their risk. Okay, moving on to our second case. And this is a true lights and sirens medical emergency. You have a patient who is acutely short of breath, and they're showing signs of shock. Now, to figure this out, you've got to understand what's happening with their hemodynamics. That's the key. And here's the diagnosis, a massive pulmonary embolism. What's happening is a catastrophic chain reaction. A big clot gets wedged in the pulmonary artery, creating this sudden complete blockage. Instantly, the pressure that the right ventricle has to pump against goes through the roof. But here's the thing, the right ventricle, it's just not designed to handle that kind of sudden pressure spike. So what happens? It starts to fail. It's like a massive traffic jam on a highway. The pressure backs up, first into the right atrium, and then it spills backward into all the systemic veins. Now, this is the money slide for differentiation. How do you tell this kind of obstructive shock apart from, say, hypovolemic shock? It all comes down to the central venous pressure, or CVP. With the PE, because everything is backing up from the right heart, the CVP is going to be high. But in hypovolemic shock, the tank is empty, right? There's just not enough blood volume, so the CVP will be low. It's a really fundamental difference. One is a plumbing blockage, the other is just not enough fluid in the system. All right, case number 3. This is a total classic, and it's often found by accident. An older male patient comes in for a routine checkup, and you feel a pulsatile mass in their abdomen. When you see that, your brain should immediately scream one thing: abdominal aortic aneurysm, or AAA. So where does this usually happen? Let's get specific. For any exam, the number one location you need to know is the infrarenal aorta. That's the part of the aorta just below the renal arteries, the ones feeding the kidneys. And this isn't just a fun fact. It's critically important for surgery. Why? Because the closer that ballooning artery gets to the renal arteries, the trickier the repair becomes, and the risk of damaging the kidneys post-op goes way, way up. And the cause of all this? Usually it's good old atherosclerosis weakening the aortic wall. So let's boil it down to the high-yield points. The key pathology? Atherosclerosis. The classic location? Infrarenal aorta. Yeah, sure, thoracic aneurysms happen, but for your exams, the abdominal one is the one they're going to ask about. And the big differentiator to always keep in mind is that the risk of rupture goes up as that vessel gets bigger and bigger. Okay, our last vascular case, and this one has a huge demographic clue. We have a young woman with really severe high blood pressure that's super hard to control with the usual meds. When you see that presentation, you can't just chalk it up to standard essential hypertension. You've got to start thinking about secondary causes. So what's the mechanism? Well, it's a really powerful hormonal cascade. It all begins with a stenosis, a narrowing, of the artery going to the kidney. Now, the kidney doesn't know any better. It feels that reduced blood flow and thinks the entire body has low blood pressure. So what does it do? It freaks out and pumps out renin. That kicks off the whole renin-angiotensin-aldosterone system, which then cranks the body's systemic blood pressure up to the moon. And what's causing that stenosis really depends on who the patient is. In a young woman, like our case, the classic cause is something called fibromuscular dysplasia. In an older person, you'd be thinking more about atherosclerosis. The absolute key pearl here is that the kidney is being fooled. It's launching this massive counterattack to raise blood pressure when it absolutely shouldn't be. And that's the high yield point. In a young person with hypertension that won't quit, you have to consider a secondary cause like this. Okay, let's switch gears. We're moving on to our next section, which is all about classic findings you'll see on a pulmonary exam. Okay, case number 5. This one is straight out of the textbook. A tall, thin young guy suddenly gets sharp pleuritic chest pain and feels short of breath. This is the absolute classic presentation for a spontaneous pneumothorax. So, what are we going to find on exam? The basic problem here is that air has leaked into the pleural space, that little area between the lung and the chest wall, and that air pushes on the lung, causing it to collapse. This simple fact explains the classic triad of findings perfectly. First, you'll see less chest movement on that side. Second, the breath sounds will be gone, or at least super quiet, because that layer of air is basically insulating the sound. And third, and this is key, when you tap on the chest, when you percuss, it's going to be hyper-resonant. It'll sound like a drum because you're literally tapping on a big bag of air. Now, this table is pure gold for your exams because it helps you tell these things apart. Just look at the percussion note. For a pneumothorax, it's hyper-resonant, like a drum. For a pleural effusion, which is a collection of fluid, it's stony dull. And for a consolidation, like from pneumonia, it's also dull. So that combination of hyperresonance on percussion with absent breath sounds, that is the unique signature of a pneumothorax. All right, next case. And it's another one you'll see again and again. A long-term smoker comes in, they've got that classic barrel-shaped chest, and they're getting more and more short of breath over time. This whole picture just screams emphysema. So what's the fundamental issue in emphysema? It's the destruction of the alveolar walls, those tiny little air sacs. When those walls break down, the lung loses its elastic recoil. It loses its springiness. That means it can't push air out effectively. So air gets trapped inside, leading to this chronic state of hyperinflation. That's what causes the diaphragm to flatten out and why the breath sounds are so faint. Those big pressure swings inside the hyperinflated chest can even cause something called pulsus paradoxus. Here's a really important clinical pearl to remember. Emphysema is a problem with the lung's architecture, right? The actual alveoli are damaged. It's not mainly a problem of bronchospasm, like you see in asthma. So if your patient is wheezing a lot, that's a clue that there's probably something else going on too. Maybe some chronic bronchitis or asthma on top of the emphysema. It's not a feature of pure emphysema. And for our final case, we've got a really ominous finding. A middle-aged patient, a smoker, has a pleural effusion. They drain the fluid, and it's blood-stained. This is a massive red flag, and it means you need to figure out what's going on fast. Look, when you see a bloody pleural effusion, particularly in a smoker, your number one thought has to be lung cancer. The reason why is pretty straightforward. The tumor grows and invades the pleura, the lining of the lung. As it grows, it creates these sloppy, fragile new blood vessels that just break and bleed really easily. And that blood leaks right into the pleural space, staining the fluid. For any exam, this is a connection you just have to know. Lung carcinoma is, by far, the most common cause of a bloody effusion in this context. Sure, you might think of mesothelioma, which can also do it, but it's much rarer. So the absolute critical pearl, the one thing to remember, is this. Smoker, bloody effusion, you think cancer first, period.